Welcome everybody. Good afternoon. Welcome to the next in our series of our Greater Manchester Primary Care ARRS Employers webinars. This is a joint production between the Greater Manchester Primary Care team, the GM Training Hub and Health Education England. Thanks for joining us today. We're focusing today on our trainee nursing associates, our nurse associate pathways and our GM primary care nursing pathways. So we've got a bumper webinar today for you. So thank you very much for joining us. I'd like to introduce the team first of all, if that's okay, and I'll go across the screen. So first is Liam. Do you want to say hello?
Yep, good afternoon. Liam Genyon, responsible for the comms and media, the Greater Manchester Training Hub.
Thank you. Natasha.
Hi everyone, Natasha Odita. I'm a primary care programme workforce manager at GM.
Thanks. And then we've got Rob.
Hi, I'm Rob Harris. I'm a project administrator at the Greater Manchester Training Hub.
Thank you. And I'm going to introduce Deborah, who then I'd like to introduce your team. And the reason is I've lost everybody's photos because we're on slideshow. So Deborah, over to you, please.
Yeah, hello, my name's Deborah Holden. I'm a PEF for HMR, Haywood, Middleton, Rochdale, and I am the operational lead for the TNA programme for Greater Manchester Training Hub, and I support the TNA team that are presenting today. So Danielle, would you like to introduce yourself first?
Hello, my name is Danielle. I attend Salford University and I work full-time for Exemplar Healthcare. I started before the TNA as a healthcare assistant and joined as a TNA in September 2020.
Jo, would you like to introduce yourself?
Hi, I'm Jo Hayes. I'm currently at Salford University studying to be a nurse associate. I work in primary care in South Manchester with a background in paediatrics.
Sam?
Hi, I'm Sam and I'm a TNA for a primary care GP practice in Bolton. I was previously a healthcare assistant for 13 years.
Okay. And Marina?
Hi, my name is Marina Khan. I'm a trainee nursing associate. Prior to this, I was a healthcare assistant for 3 years, and before that, I was a receptionist for 5 years.
Thank you.
Thanks, Deborah. Is that your team?
All right, I'll say yes, that's the Fab Four that have joined us today.
Thanks, Deborah. Just a bit of housekeeping then, if that's okay. Just to let everybody know, the webinar is being recorded, and whilst the presentations are going on, would it be all right if you are on mute? And there are a couple of ways in which to ask your questions or interact with the team and the speakers. We will be keeping an eye on the chat box, and also if you want to put your hand up virtually, we'll come to you. I'm not sure if Leslie Royal Pryor is on the call yet. If she is, can you make yourself known? If not,
I am Ali. I'm here.
Oh, sorry, Leslie. Would you like to say hello?
Certainly. Yeah.
Thank you.
Hello, everybody. My name's Leslie Royal Pryor. I'm primary and community nurse lead for Greater Manchester.
Thanks so much, Leslie. And Kerry, who is also part of the GM primary care team, is also on the call. Do you want to say hello?
Yeah, just before I was about to eat my tangerine.
Sorry, Kerry.
Oh, good timing. Hello, everybody. My name's Kerry Porter. I'm one of the primary care workforce programme managers for Greater Manchester.
Thank you. So thanks to everybody. So you've met all the speakers today. Thanks very much for joining us. We do have a bumper programme, so please may I hand over to our first speaker, and that's Deborah. Thank you.
What we've done today is the TNAs have developed a presentation, and they'd like to give you some information about the programme from their perspective, their experiences. And then following this will be a question and answer session, and I will give a brief overview of the different routes that we're taking now and opportunities available for the workforce in primary care. So I'm going to hand straight over to the TNAs, and they'll let me know when they want any support, and it's my turn. So over to you.
Hi, I've already introduced myself. My name's Jo, and thank you for coming along today to listen to our experience of actually living the life of a TNA and what it's like to be working in an apprenticeship. Next slide, please. So, welcome to the world of a TNA in the Northwest. It is a very exciting place to be, but it is very daunting and very challenging all in the same time, but incredible fun and an amazing experience. We are developing our skills and underpinning knowledge, not just in providing our care. We want to be the future of formulating care as well, and that's what's driving us forward in this role. We've come an awfully long way in the last 6 months. We started in September 2020 after a bit of a bumpy ride getting started with COVID, but we are working harder than ever, and we're really enjoying the experience. There's a massive difference in the way we think now into how we thought before as HCAs or physiotherapists or whatever we were before. So let's start at the beginning. Next slide, please. So firstly and foremostly, we're trained to be an accountable practitioner. So from the very first day of starting the apprenticeship, we're taught about the NMC's Code of Conduct and how we are accountable not just to the NMC and our employers, but to law also. And this knowledge that we've now got has altered the way we conduct ourselves and altered our thinking about not just our practice, but how we're going to deliver our care now and in the future. We are now more acutely aware than ever of the implications of being a registered practitioner and how following the guidelines set by the NMC, local and government guidelines, how vital that is in protecting ourselves, not just ourselves, our colleagues, patients and their family. And this knowledge has heightened our sense of responsibility massively. So secondly, promoting health and preventing ill health. We are developing our knowledge around the promotion of health and preventing ill health. And we can deliver this through a range of mediums, such as organising information boards, contributing to our employer's website via face-to-face or remote consultations, particularly during the pandemic. That's been vital. We recognise the importance of holistic and person-centred care, and we always consider this when we're promoting health in discussions such as lifestyle or encouraging patients to take part in screening programmes. We understand as well the economic, cultural and environmental conditions that can affect a patient's health, and being led by the patient, we can try and understand and break down the barriers to accessing good health. Thirdly, is provide and monitor care. So that's what we do. That's our bread and butter as a TNA. We do provide and we do monitor care. And we do this across the life course because we are the only registered support role that is generic, which I certainly feel is very important in the future delivery of healthcare, because it gives us a larger scope to practice being able to slip effortlessly really into any of the 4 fields of nursing. We're through university, we're taught the necessary underpinning knowledge and skills to do it safely and effectively. We are confident in the skills and knowledge we have been given to recognise when a patient is deteriorating and to recognise when a patient is improving and responding to treatment. So we work in teams. I'm going to leave the working in teams. We'll combine that with the contributing to integrated care, because I think they're intertwined, very closely intertwined. The other things we do is improve safety and quality of care. So we're all keen to improve the safety and quality of care for our patients, and we can do this in our everyday practice due to the knowledge that we're gaining from university and colleagues, and putting that knowledge into our practice. I have been involved in STOMP, which I'm not sure whether you're all aware of, which is to stop the overprescribing of psychotropic medications to learning disability patients and patients with autism. And I'm working hand in hand with GPs, psychologists, psychiatrists, the community learning disability team to audit this and look at the way in which we're dealing with these patients and whether that medication is indeed necessary. The working in teams, I have to say, we are great team players. It's part of our nature, and we have become more comfortable working and liaising with different teams. We're active members in our MDT meetings and are in regular contact with community services, social prescribers, GPs, consultants, and we're confident and competent in doing that. We understand the importance of the continuity of care needed for not just our patients, but for the families of those patients as well. And we contribute to integrated care, firstly by delivering person-centred care and listening to the needs and expectations of each patient and their families and carers. And we are involved in patients' care from the prevention of ill health right until the end of life. And next slide, please. And can I introduce Marina, please?
Hi, I think my slide is after this one. Danielle, yeah, it's this one. It's number 7 or 8, I think.
I think these slides are the old ones. I don't know who's doing them.
I'm so sorry about this. The one after this one, please. Patients, and then after this one as well, please. Sorry. Right. Hi, my name is Marina. I'm a trainee nursing associate. So becoming a trainee nursing associate can be overwhelming. When it first started, when I joined it in September 2020, it was a bit overwhelming, but it's been 6 months now. And we've come so far, and I can do so much more compared to as I was before. And it's amazing how it is. And all the support that we get from all our health education institutions, our employer organizations, and our practice education facilitators is amazing. From day one till present, and till the end of this program, they're always there for us. Whenever we need any help, they're there, and it means the world to us. This trainee nursing associate programs give us the opportunity to work with different professionals and in different environments, and that is what makes us generic. For example, at the moment, I'm in a primary care setting, and I know how a primary care setting works, but I will get an opportunity to go and work in hospitals and get to know how other healthcare professional works, what their duties are, what they can do. Where my knowledge ends, their knowledge begins. So this program gives me the opportunity to understand hospitals better as well, and every other setting, social care setting. And that is what makes us generic. Trainee nursing associate is the only registered generic support role, and it allows us to lower the workload of the registered nurses so that they can then focus on more complex work. Next slide, please. So why is apprenticeship the best way of learning. It is the best way of learning because we get to gain more new knowledge and then we get to put it in practice straight away, which is amazing. It's not like you've learned about something and then it's been there for a while and you've not practiced on it. You get to learn and gain experience straight away, and that's the best way of remembering, keeping your knowledge fresh. University lectures are very well structured. It doesn't matter if you've never been to a uni before or if you've not studied for some time. All the lectures are very well organized and gives you all the information step by step, so you don't feel overwhelmed, you don't feel scared of going to university. It was a dream to go to university. It was my dream, and it's a dream because of this program. It's a dream come true. And being in a healthcare profession is about serving humanity. So the support that a trainee nursing associate needs to be able to serve humanity, not as much, but in a little way, the support that we get for that is like, for example, each and every person, the practice assessor, the practice supervisor, the PEF, practice education facilitators, the universities, the practice manager, employer, each and every person is giving from their own cups their precious knowledge, time, skills, experience into our little cups to make us able to serve humanity in our own little way. And I think it's a very noble thing. It's an amazing thing that what they're doing. Every day we get to apply or increase knowledge into our practice because of this apprenticeship, the way apprenticeship is. And we have a further opportunity towards the end of this program, where after doing 2 years of trainee nursing associate, we get to learn about cytology as well. So again, we will be able to do more and deliver more. Now, about loyalty, I would like to say is that it's a life-changing experience for me becoming a trainee nursing associate. It opens so many windows for me, so many doors for me. And it's amazing, and it means so much to me. And it's all because of my current employer. They gave me this opportunity, because of my manager, because of my practice assessor, supervisor, the PEF, the university, each and every person. And it means a lot to me. And that is what will make me stay with my current employer as well, because it means a lot. And it's not an act of kindness of one-off, it's an act of kindness of a lifetime. That's how it feels to me, to each and every trainee nursing associate. And from employer's point of view, it's a day in a university, a day as a supernumerary, where we are under supervision, learning new skills and putting them into practice, and rest of the time is business as usual. If you look at it as it's a short-term loss for a long-term gain, it's amazing how the whole program is. Next slide, please, and I would like to pass you on to my colleague Sam now. So if you go back, please, sorry.
Thanks, Marina. Oh, this is mine.
Yes.
Okay, hi, my name's Sam. I have introduced myself. So I work for primary care in Bolton. Okay, so why invest in a TNA? They're a new support role which are built to bridge the gap between healthcare support workers and the registered nurses, enabling employees to provide the best possible care to their patients. We are generically trained to work across all fields of practice like registered nurses, and the roles taught us to be more confident and competent in ourselves. With our new underpinning knowledge and skills we have gained, gives us the ability to deliver the care in a holistic, person-centred way. We no longer have to seek help from team members as often as we once did. We're now self-questioning and always striving for the best possible outcomes for our patients and their families. We've also put together some feedback from colleagues and patients on the next couple of slides. So I'd give you a moment to read. I think the first slide is the patient feedback. So I'll give you a moment to look through those. And on the next slide, we have some colleague feedback, which shows just how much we have come on in 6 months on the TNA course. Okay, I'm now going to pass you on to my colleague Danielle. Thanks for listening.
Hi, can I just apologise? Firstly, my neighbours have just decided to do a bit of DIY, so you might hear a bit of banging. I'm so sorry. I'm Danielle, and like I said before, I attend Salford University once a week. I have been a healthcare assistant and a senior carer for 13 years before starting the teenage journey. I started the teenage journey because I wanted to do more to promote health and prevent ill health and dig deeper into my career. But in our cohort, we've all started in different places in our lives, such as healthcare assistants, teachers, mums, dads, physiotherapists. But we all shared that same dream to progress our careers, to do more, to make a difference in people's lives. And this drove us all to the excited world of the degree apprenticeship. Being a healthcare assistant for 13 years, I thought I knew it all. But the mandatory training that you do as a healthcare assistant is totally different to being in uni. You learn a lot more. It's more in depth and you dig deeper to widen your knowledge as a healthcare professional. So it's not just about doing your everyday tasks at work, you see everything as a whole, holistically. I have learned a lot more in practice and in uni. The support that we get from the university, our employees, our PEF team, it makes a huge difference, and with knowledge comes confidence. When starting in September, doing a presentation would have been my biggest nightmare, but now I feel like I have grown as a person and in confidence, and I'm now doing this presentation voluntarily. I promise I was not forced to do this. How did I know it was for us? In all honesty, I didn't know if it was for me or if I could do it. We didn't have much knowledge on the TNA programme because it was all new to everybody, and this is why we are here today, to promote this amazing TNA apprenticeship and to make people aware of it. The thought of uni scared the life out of me because I'm not academic one bit. I've not been in education for over 16 years, but I thought I would give it a go because I'm not getting any younger. I am so glad I did, and I would never look back. When starting this TNA course, it was very overwhelming and very challenging at times, but once everybody got their heads around it, it was so much easier. And obviously the pandemic didn't help, but again, the support that we got online, it's just been second to none. And if I can do it working full time, 2 young children, anyone can do it, and I would 100% recommend this apprenticeship to anybody. Can we go to the thank yous, please? I'd just like to say thank you for everybody coming to listen to us today. Thank you to Josie and Deborah and their support, and the fantastic team of University of Salford and Bolton. Thank you to everybody that believed in us from the start, who put us on the course. We appreciate every single one of you. Thank you very much.
Well, thanks so much to all of you, Joanne, Sam, Marina and Danielle. That was a absolutely beautiful, humbling presentation, and you should be absolutely very proud of yourself. Thank you so much. I'm sorry the slides were a bit back to front, so you managed that exceptionally well. Absolutely a big thank you from me. Deborah, lovely. Deborah, do you want to carry on?
Yeah, absolutely. Liam, if you could pop the slides up, please. Okay. So I want to give you a little bit of an overview of the opportunities, how to develop a trainee nurse and associate in primary care, because as you'll see with our lovely ladies there, the 4 of them have gone through the apprenticeship route, but there are other routes into primary care developing this workforce. So there are currently 3 routes available. If you could go on to the next slide, please, Leah. Now, there are 3 routes that you can access. You can do down the apprenticeship route, where you've got an employee yourself and you choose to develop that employee. So we call that grow your own. We then have the ARRS, and this is about new blood, and that's really what we need to do. It's lovely to develop your own, but we also need fresh people to be employed within primary care, within that workforce. And that is where you would put an advertisement out for a trainee nurse and associate, and you would employ them. So this is your new blood. And then we've got a 3rd route, and that's self-funding trainee nurse and associates, and we call these try before you buy. So this is where we engage with a university, and they place a student trainee nurse and associate with you for a significant amount of time over their 2-year training. So we call that try before you buy. So if we just look at some of the similarities and differences, and you will see which is best for you, for your workforce in developing them. So what we do with the apprenticeships, there are 2 intakes a year. So even if you have somebody you want to develop yourself, or if you want to employ somebody by putting an advertisement out, we have 2 intakes a year. Okay, that's what we do. But with the self-funding, there's only 1 intake a year. All right, so there are 2 opportunities all the way throughout the year to develop this workforce. But as you can see with the ARRS funding, you would want to recruit them new. And you may do that as a primary care network and do that collectively and recruit TNAs. So you would have to be employed for a minimum of 30 hours a week if you had an apprentice. Again, if you wanted to recruit somebody new, they'd have to do a minimum of 30 hours a week to comply if you want to train them over 2 years. And ideally, you don't want to train for longer than 2 years to be a TNA. A student with the self-funding route, you don't employ them at all. You don't pay for this student. You do receive a tariff to get these students. Okay. So then if we look at the entry requirements, again, if you've got a member of staff who's been out of learning for a long time, maybe 15, 20 years, but they've got potentials to develop, what we would do is put them on a career pathway once they put through that expression of interest. We would help them to get the level 2 maths and English, which is the essential criteria for this programme. So whether you recruit somebody independently, new blood, or whether you grow your own, they've still got to have that basic. For any apprenticeship, they must have a level 2 in maths and English. And if they put an expression of interest into us and they think they want to do an April intake and we see that they've not got those qualifications, then we will support them with providers. We will guide them onto the level 2 maths and English, and then by September or possibly the next April, they will be ready to come on one of these programs. Okay, now obviously if you want to recruit somebody in an advertisement, you would, for a TNA program, you would say the essential criteria is level 2 in maths and English, and then you would recruit them, and then we put them straight onto the program once either the April or the September cohort become available to them. They are all doing, no matter what route you employ them by or develop them, they're all doing the same programme. They're doing the 2-year foundation degree in nursing associate. There's no difference in it. They all do that same programme. They can all come out with the same qualification. The only difference with an apprenticeship is that they do an endpoint assessment. So their apprenticeship, they register at the same time within 2 years. And then at the end of the 2 years, if you do an apprenticeship, you then have to do an endpoint assessment. And that takes approximately 3 months post-registration. So there's very little different in them. Regarding the teaching, so this is about the impact. This is about losing your workforce for a particular amount of time. When you're on apprenticeship, there's a requirement that you go to university 1 day a week. And that's what they do. Now, we work with 2 universities, Bolton and Salford, and what that would mean, what that looked like practically during COVID, we've all gone virtual, they all do 1 day a week. Now, when we come out of this, and we will come out of this, it's going to look different, Bolton will always do 1 day a week, day release, bog standard. The University of Salford tend to do it in blocks. So this may suit your practice more. I don't know. These are the decisions that you can make. They teach your student for a week, your TNA, and then they come out in a block clinically. All right. And then what they do is they ask them to do 1 day a week for 7 weeks. So over 18 weeks, they'll have a block, come out, block of teaching, come out to your practice for a block where they then don't go into university. And then the following 7 weeks, they'll go 1 day a week into university. So that's how they do it. They sort of blend their teaching. And you need to decide which is the best for you. Okay, now that's the same whether you do when you do ARRS, because if you're putting on the apprenticeship route, it will be the same. Apprenticeship route is apprenticeship route. But if it's self-funding, what we do is they do a block in university and then they come out to us for a block of 12 weeks. Then they go back to university again. And then at the end of the first year, they come out to again for a block of 12 weeks. You get the same trainee. So say your primary care network together has decided to offer the opportunity to train in primary care to 5 self-funding student trainee nurse and associates. What would happen is you would get the same ones. So the first 12 weeks that come out, it will be very much an introduction to primary care. But by the end of that 12 weeks, they're really developing some skills. That's 3 months. And then they go back to university to extend that knowledge. And then they'll, at the end of that first year, they come back out to you. They'll have the knowledge and clinical skills they previously achieved, but more knowledge, and they will develop more skills in primary care. And they do that over the 2 years. They keep coming back to you and you keep developing this person. So that's why we say it's try before they buy. Does it fit you? And does it fit this individual? Is primary care for you? But what we're doing, rather than focusing their training on in the acute setting, we're focusing the learning environment in primary care. So we're evening it out here so that we get a fair shot at recruiting these trainee nursing associates into nursing associate roles. They'll be familiar with the team. As soon as they register, they hit the ground running, which is just fantastic for us. So with the apprenticeship or hub and spoke model, that means they're based in your practice. If they need to get additional exposures, they need the same settings as nurses. So at home, close to home, in hospitals. They need to work with the same fields. So the fields are, as I'm sure you already know, adult learning disabilities, mental health and child. So that means they can transfer those skills into all the different environments. But that's an NMC requirement and they must do that. And so must the nurses on the trainee on the self-funding ones. But what they're doing it in a block. So whereas your apprentice, it's a hub and spoke, you keep that member of staff. It's a hub and spoke for the self-funding where you get them for a block and then that student goes back. The programmes are mapped over 2 years. So that means that we have to meet the apprenticeship requirements. So that's the off-the-job learning. So if we wanted to look at an atypical week for an employer, 1 day in university. If you're at Salford, it's the equivalent of only 1 day in university. But as I've explained, they may do it some in blocks, some in day release, and then a full block in clinical, okay, but over the same week. And that pattern's repeated. There's 3 semesters a year, and that pattern is repeated 3 times each year. If you're an apprentice, a paid apprentice who's developing a grow your own, they stay with you. They only go into the spoke placements when they need those additional exposures for the NMC. So 1 day a week. So the other times, if they're full time, that's taken 1 day away from you. 3 days, they're clinical. They will be doing their existing job, but the difference is an apprenticeship, you must evidence learning all the time. So at the beginning of sessions with their practice supervisors and assessors, you agree with them what they would like to achieve over the next 3 days. And then at the end of that, you revisit it and say, have we achieved these objectives and can we evidence learning? So the clinical, developing the skills and knowledge over the 3 days. Now that leaves 1 day. That other day, they are supernumerate. That's off-the-job learning, that's PLTT. There's different languages for it, whether you're looking at the NMC requirements or the apprenticeship requirements. But what it means is basically they're not in your numbers. They might be shadowing somebody, they might be working hands-on, but if you take them away, they're not vital to your numbers, and they have got to be learning. So you might want them shadowing a nurse, where you will eventually want them to take over that task. So over one semester, you'll say, right, this is where we're going to start. You're a real novice now, but at the end of 18 weeks, you're going to be an expert. And we know with indirect observation, you'll be able to run that clinic. And that's about an apprenticeship. That's continually developing somebody, and that's how it works. Obviously, with the self-funding, you'd start to develop them at the beginning of the 12 weeks. And then at the end of it, you'd want them to be competent and quite proficient at what you want them to do. Okay, next slide, please. I'm sorry that I'm ploughing through this so quickly. There's so much information. So what's that during block place? So I've explained about the placements, the funding. Okay, if you want to have an apprentice and develop somebody yourself, what we do is we get the levy gifted to your organisation. So that means we get larger organisations with lots of apprenticeship money, with lots of funding to gift you that money to develop somebody in your workforce. And that's what everybody wants to do, because the last thing we want to do is waste apprenticeship money. And there are so many organisations that are keen to give 100%, the £15,000 for you to develop somebody that is going to stay within your workforce. Okay, with ARRS, obviously you get the money through the ARRS scheme to pay for that person's employment, but you also get the money gifted from the apprenticeship levy to that goes to the providers, whether that's University of Salford or the University of Bolton. So it really is a win-win situation when you're going to do it as a primary care network and develop those people. With the self-funders, there's no cost to the practice at all. It's all funded, and the student get the student, what's it called? They have to pay it for themselves, as you know. I can't think of the right word, what it's called. Regarding HE funding to support you and your staff, it is actually with the apprenticeship, you get 8,000 over 2 years. You do get that in 2 payments in year 1 and 2 payments in year 2. And because what we're doing at the moment with the current cohort is putting a primary care specific element to it, so there will be cytology training at the end of it. We do support you with getting the uniforms and the badges and things like that. We do take a small portion out to pay for those, but we're quite transparent about it, and you do see that payment. Regarding the ARRS, the 8,000 would go directly to you, and as employers you would do that yourselves, and the university provides a uniform for the students and everything like that, and you get a tariff of 4,000 over the 2 years for them being placed with you. And I've said here the ARRS scheme, it can be applicable if you're growing your own for nursing associates, if you're getting nursing associates, but really you need to employ them as, put the advert out for TNAs and do it as a primary care network, because if you're doing it as an independent practice, you won't be able to get the ARRS, so you do have to do it as a primary care network. And the ARRS scheme isn't available to self-funding. I've mentioned about uniform. What time will it take for your other staff? You need a practice supervisor that can work alongside when needed, that trainee. You need an assessor, so when that supervisor says that person's ready and they think they're proficient and confident and competent, that assessor can then work alongside them and say yes, they actually are, and sign them off. It's not a onerous job. It takes time at the beginning, but once you get used to it, it flows really, really quickly, that process. You need a practice supervisor and assessor, whether they're self-funding or whether it's apprentice. You do get the support from the PES team, you do get the support from the training hub, and we have clinical educators, wombats and all sorts from the universities. If it's self-funding, you get the PEF team to support. You don't get the wombats, you don't get the clinical educators, you get the dedicated PEF team as you do with any students. You do get the whole point of growing your own is so they stay in your workforce, so you have the loyalty, and you could see from the TNAs how committed they are to working within this workforce. It's negotiable. If you develop somebody, if you employ somebody to do a training program, usually you would expect that they will stay with you post this program. And with a self-funding, there's no obligation, but if you're developing somebody committed, you'll usually find that they do want to come back and work in primary care. I've already explained that the programs are run on an annual basis, and we have 2 intakes for the apprenticeships. Next slide, please. Almost there. So there is a trainee nurse and associate career pathway available to your non-registered workforce. That's a message that we need to get out there. There are different points of entry tailored to the educational requirements of your members of staff, whether they've already got qualifications, part qualifications or no qualifications. There are options for the employers. As you can see, there's 3 different options there. You decide what's best for your workforce. And if you want any information, I am available. Thank you.
That was brilliant.
Thanks so much.
I just wanted to really, congratulate and commend the TNAs because I could see how magnificent they are and how brave they are as well, stepping forward. And, starting, 6 months into a training programme during a pandemic, I just think it's amazing. And absolutely, you can see, their passion and their determination. So well done.
Yeah, thanks so much, everybody. We've got some questions coming up in the chat, and it actually is, Deborah, please, can you share your contact details? And I'm a bit behind on the questions, but there's a lot of support in the chat for the TNAs in your team, so thanks so much. Natasha, scrolling through, can you see any questions? Because I have a few.
I can't see any questions now.
Thanks, Natasha. I've got some daft questions then. So the thing I didn't know was that the TNAs are trained in adult, child, mental health and learning disabilities. Is that right?
That's right, yeah, they have to cover exactly the same fields of nursing as nurse. That's what makes them generic, so that they can actually work in all the different environments.
Wow,
and have to have the exposure.
So actually for general practice and working in primary care situations, actually that skill set that the TNAs are acquiring is exceptionally valuable. Exceptionally valuable. Sorry, I didn't know that. So so that's a new one on me. In terms of TNAs, can I just clarify? They definitely are. If you support a TNA, is the salary component reimbursable under the ARRS program? Is that correct?
It's only under the primary care network, so it's reimbursable.
Okay.
If you do it as an independent practice, then it isn't. But if you do it as a primary care network, it is. So at the moment, I believe that we have got a primary care network. It's the same for NAs and TNAs. We have a network who have just employed 4 NAs. So then they can get that reimbursement. But when they do it as individual practices, they don't, because they're not doing it as a primary care network.
Yeah, sorry. What I meant was when you're training to be a nursing associate as a TNA, and say you're in a primary care network, so you're eligible in that way, are you eligible as a TNA for ARRS reimbursement rather than just
not as far enough. If it's within a primary care network, it goes to the primary care network, the payment, doesn't it? But at the moment, because they've not been recruited as TNAs, these are all the ones that we currently have been recruited independently by the practices. So as far as I'm aware,
sorry, Deborah, what I'm trying to say is any new ones recruited by a primary care network, but if you are a TNA or a fully qualified NA, your salary part is refundable, is eligible under the ARRS program. As
far as I'm aware, I mean, Natasha is more the expert than me on ARRS, if I'm completely honest. I'm batting that little one a bit back, but as far as I'm aware, you can, as a primary care network, yes, if you're training a TNA, then yes, you can, under the ARRS scheme.
Yes.
Thanks so much. And I've got one final question, and it's around, you know, developing our colleagues from healthcare assistants, assistant practitioners to registered roles. And I know in the early days there was some discussion around whether colleagues who are already assistant practitioners who've done some, is it level 4 training, can we develop them as TNAs, or are we still in a sticky position?
At the moment, we cannot get the funding. If you want to APL onto a TNA programme, you have to have at least 12 months of learning to do in order to qualify. And you will find when the majority of them APL over, then they have more than 12 months of learning in hand, because you cannot be retaught, you will not be paid to relearn something that you already qualified at a level 5 for. So at the moment, a practice has come back with a query, is there any way around this? Because the person doesn't want to go on to do the RNDA programme, but they do want a registration. They want to be able to top up, if you like, to do the things that the nursing associates can do. So what I'm going to do is I'm going to speak with our university colleagues and see, is there a self-funding route to this? Can they do a fast track course that just picks up what they've missed? Is this an option? I don't know is the answer. We want to have those discussions. I don't know that, but it just seems a shame that we're closing the door on people who don't want to do another 3 years plus. So let's see if there's an opportunity there, but I've not had the formal discussions, but that is one of the ideas that maybe we can take forward.
Thanks, Deborah. Hi, Chris. Do you want to come in?
Hi, afternoon all. Thank you very much. I've got a noddy question because I like my noddy questions. I love this. I love this scheme. It's brilliant. The apprenticeships, if that's £15,000, that pays for course fees, does it? Does that pay university fees over the 2 years? There's no cost to practice. Thank you for that. Is there a cost to the individuals who are wanting to go on the course, or is that all covered? That's brilliant. We need to enthuse about this in Trafford, certainly, don't we, Henrietta, and other people on the call, and across GM, sorry. That's really helpful. I'll be in touch. Thank you.
Thanks, Chris. So I think where we're moving to now, are there any more questions?
I've got one in the chat, sorry. So Tony from the Valence Centre has asked, what's the availability of the Fund Your Own scheme?
So the Grow Your Own. So if you've got somebody that wants to be developed, is that the one we're speaking of?
Well, I think he's pertaining to.
No, I meant we're talking about numbers. What kind of numbers are available when they do the intake every year?
There isn't a cap on the intake. The whole initiatives at the moment is to increase the workforce. So there isn't a cap. They will never turn somebody away that's got the right knowledge, skills and behaviours and desire to do this course. They don't turn people away. We'll find a place for them. Does that answer your question?
Okay, thanks very much. Yeah, because I mean, self-funding. I mean, this is sounds like a route, you know, for someone who perhaps hasn't got a professional background. It might be quite expensive to self-fund. I'm just wondering, in terms of, are there throngs of people knocking on Salford asking, can you find me a practice, or are we talking 1 or 2 people a year who are going down the self-funding route, who perhaps might be split between all of Greater Manchester?
So we chose to work with MMU just for this intake because they reached out to us, and they recruited 65 self-funders. this is the first one that they've done. But what they need to do is they need to find somewhere placements at learning environments for these students. So they reached out to primary care, and we said, of course you can develop these skills in primary care, allow them to come for us for these extended placements. But what we want is continuity for the students and for the practices who are investing, their staff are investing on training these. We want them to keep coming back, and we want to show you that we can develop them and they can develop their skills within primary care. So that's what we've done. So they will supply us with as many students as we feel we can support and give a valued learning experience to. And you will find that those students now, if we get feedback from them, I can guarantee it, it's overwhelming. They are gushing about primary care and the time people spend with them and the opportunities that they have to develop. So yes, as many people as come forward, practices, we will find you self-funding students.
Thanks for that. Sonia, I can see you've raised your hand.
Hello, it was just on the question about numbers, and I love TNAs. I think they're brilliant. My husband's about to become one, so in 2 years' time that might be different, having lived through it. But the 50,000 target for nurses, the manifesto commitment, I think there's going to be a real push to increase TNA numbers because they're going to qualify in 2 years. I think along with that, the funding for HEE for 21-22 hasn't been announced as yet. So what that support looks like, we're confident it's going to come. We are planning meetings for as soon as that information lands so that we can then translate that and work with our training hubs to say what the offer for 21-22 will look like, because it might be slightly different, it might be the same, but it might be tweaked a little bit.
Thanks, Sonia. Thanks, Deborah, and thanks to Joanne, Sam, Marina, and Danielle. Thanks so much for coming. I'm hoping now we're going to move to Leslie and to talk about the nurse associate pathways. And actually, I hope, Leslie, because my next question is, as a registered professional, what roles and procedures can the nurse associate undertake greater than a HCA or assistant practitioner? So I'm hoping that's covered.
I hope that'll answer your question. Yeah.
Excellent, Leslie. Over to you.
Okay, can I just start by saying what everybody said, but it was just a fantastic presentation from the ladies there, Marina, Danielle, Sam and Jo, knowing what fantastic work HCAs do in general practice already, and probably some of the struggles they had, because I was there in the early days of the TNA programme getting started to get on this. It's phenomenal, and your presentations were fantastic, ladies. Thank you for that. So if I'll have the first slide, please. So trainee nurse associates and nurse associates in primary care. Next slide, please. So the vision and strategy. So the future of primary care in Greater Manchester. Some of you may have seen this slide before, but the vision of a transformed primary care that's got a skill mix that's responsive and appropriate to our population needs. And to achieve that, we need to look at a workforce to make this sustainable. So we need to improve the career pathways of nursing, develop our internal talent, improve the pipeline, provide additional capacity and embed new roles. And that's just what we're doing here today. Next slide, please. So this is a slide showing the breakdown, which we're probably all quite aware of general practice nursing approaching retirement in the next 5 years from the localities. And you can see that puts pressure on our primary care and the health system and the increasing workload. So that's just where our change in the nursing workforce comes in. Next slide, please. This is more recent numbers. So this is from November last year. just shows a stark figure there of our GPN colleagues across Greater Manchester, and that there's 33.6% that are aged over 55 now. And the highlighted numbers there of the older numbers, so you can see we're actually an older workforce. Next slide, please. So what can we do to improve the primary care nursing vision? So improve the career pathways. We can, as we've said before, grow our own workforce by developing new roles that will bridge the gaps in nursing, offer opportunities for internal staff to develop and gain new skills, and along new clearly defined career pathways like the nursing associate. We can attract new talent into roles by offering alternative ways to learn and progress through apprenticeship schemes, and we can support primary care to embrace transformation by embedding these new roles that will release capacity and enable primary care to focus on preventative care. Next slide, please. So in Greater Manchester, Deborah's discussed this earlier about the foundation degree apprenticeship and the time at university, and the ladies described this fantastically as well. So we can move on from that. Thank you. Next slide, please. So, Ali, what can a nurse associate do? So the presentations earlier told you some of the phenomenal things that they're doing now as trainees, really being involved in the STOMP project for one, something that probably as a healthcare assistant they would never have dreamt of doing at all. So some fantastic ideas there. But because this role is designed, as Deborah said, to bridge the gap between the healthcare assistant and the registered nurse, it will free the registered nurse, or as we're talking in general practice, the GPN's time, allowing them to do more complex clinical duties and patient care. So while the nurse associate will contribute to most aspects of the care, including the delivery and monitoring, the registered nurse will take the lead on assessment, planning and evaluation. So the areas where a nurse associate will become involved will be long-term condition management, health checks, cervical cytology has been alluded to before, immunisation and vaccinations, and that will allow the
Hello? Hi, Mum, you're right.
That will allow the practice nurse.
Sorry, can everybody go on mute, please? Thanks so much. Sorry to interrupt, Leslie.
It's fine. That will allow the practice nurse then to take on more complex clinical duties of patient care. Next slide, please. So things to consider, as Deborah said earlier. So do you have a vacancy in your practice? Do you have a healthcare assistant that you could support to develop? And do you need these staff in your networks? And my answer would be yes, definitely. These are going to be your nursing staff of the future, definitely. It's a flexible workforce. It keeps pace with development. We're widening skill mix, and we're developing expertise and knowledge. Next slide, please. So future prospects for nurse associates in Greater Manchester then. So trainee nurse associates for pay scales reflecting their value. So a band 3 whilst training, and once qualified a band 4. Career progression, so developing them on to registered nurses and beyond. Education and development, so supporting their education and development in new ways of working. And that also includes looking at a foundation programme for nurse associates that may be coming into primary care from secondary care, so to bridge that gap for them into primary care. And encouraging more trainees into the role as a valued member of the nursing and general practice team. Thank you.
Thanks, Leslie. I mean, this has been a really, really good opportunity to just explore the career progression from healthcare assistant to trainee nursing associate to registered nurse and beyond, and this is an absolutely critical thing, as you've shared, for delivery of really great general practice care in Greater Manchester, because our nursing colleagues are safety critical and actually really do deliver the health promotion and chronic disease management aspects of general practice. So it's really good to see this in context. Any questions for Leslie? So I'm going to ask my question again then, Leslie.
Go on.
So just so I've got it in, so with my general GP head on, so in terms of what kind of skills and clinics does having a registration with the NMC mean that colleagues can actually do? Because yeah, I just want you to share what additional roles they can do, colleagues can do.
So they can do most of the work that a practice nurse will be doing, apart from prescribing.
Wow.
Yes. Wow.
So IMS and VACs?
Yes.
Pill checks? Not the prescribing part,
not
but
the prescribing
check
part. Yeah. Yes.
Wow. Okay, and then the complex chronic disease management could sit with our general practice
That's
nurses.
right, yes. Yeah. So the more complex work would sit with your GPN. Yeah, definitely. Definitely.
And have you got any thoughts from our GPN colleagues on what they feel about building that team? Is that, well, I mean, I would like to think that's a welcome thing. Is that how it's sitting?
I feel that it is, yes. I think there's been, in the Northeast, there's been a lot more nurse associates been brought into primary care, and they are working in very, very different ways. They were a pilot site for nursing associates, and they've been working in some quite different ways in general practice. But I think it's exciting, yeah, and I think most nurses will want to develop teams, yes.
Yeah, I agree.
Encourage it.
Tony, do you want to come in?
Yeah, sorry, I'm quite new to this, so forgive me if I'm asking a really stupid question. So after the, let's say we have an HCA who wants to take their skills up level, they go through 2 years of this university level. Afterwards, do they have to do, I mean, what's their CPD like at that point if they want to stay on at that level? They don't want to pursue, say, going all the way to a registered nurse. Do they still need to be at university, or do they? What's the career path at that point? Do they just go into the PCNs, work full time, have CPD sessions like a nurse would, or how does it work at that point?
So they'll still be accountable to the NMC, so they still have to do their continual professional development and revalidation as well as a registered nursing associate. So like your practice nurse or any other nurse that works in your surgery, they would have to keep updated, yes. So the programs...
It wouldn't be 2 days a week?
No. It would be as your nursing staff would do now. So just their CPD.
So it's an investment for 2 years, but after 2 years, it's all, pretty much 100% of their time can be reimbursed by ARRS.
Definitely.
And is there anything stopping us from putting like a contractual obligation to stay on afterwards if we were to take them on for, say, a few years to make sure that investment, a tie-down contract or something like that?
I imagine that's up to the network to make that decision.
I think Tony is, from what Tony's sharing, I think my thoughts have gone to the next level. Given the courses that are NGM at the moment, the Bolton course and the Salford course, do the TNAs come out as nursing associates GP ready, or would they require additional training to be GP ready? You know, like the foundation program. What's your view, Leslie?
My knowledge, and Deborah will probably back me up on this, hopefully, is that there is an additional element to the course now that makes them GP ready. Yes, so that's cervical cytology at the end of the course. Yeah.
Okay, so they can do smears as well.
Yes.
Wow. Okay.
So what we're currently doing is we're tailoring the generic program to primary care to make sure that they will have the skills on registration to apply the knowledge within our setting. So that's to look after patients at home and close to home, but they would also have the skills and knowledge to look after them in the hospital. So we're adding on to our train, and that's the tailoring of the program. Now, once they register, there's certain things they're not allowed to do until they register. So this is again what we're looking at with the preceptorship. Really, once they register, then with this first cohort we will automatically put them onto the cytology course. So that's 6 months program, so they all know that they will be doing that, and after 6 months they will then be able to do the cytology as the registered nurses. So there are many things that we have embedded within this, within their off-the-job learning, that time that we spend with them, that means that they will hit the ground running once they get that registration, or possibly within 6 months with the courses they have to do post-registration.
Okay, thanks so much for that.
And we are developing a programme, as you know, Ali, to support that for nurse associates that are coming from secondary or community care, so that they are GP ready as well.
Brilliant. Thanks, Leslie. Hi, Henrietta. Do you want to come in?
Yeah. Can I play devil's advocate here, Leslie? You would be disappointed if I didn't, wouldn't you?
Yeah.
So why would general practice then, once they've got an all singing, all dancing nursing associate, ever bother to have a nurse in place? When you've got a nursing associate who's a band 4 and she may have all of the skills you require. So it's just a query. I'd like the doctors to answer that one. Chris?
No, it's a good one, Henrietta. But it's because that there will still need to be a registered nurse to oversee the care planning.
So you could have 5 nursing associates and 1 registered nurse?
You certainly could, yes.
Yeah.
Chris, have you got any thoughts?
You're mute, Chris. Still mute.
Sorry, can you hear me again?
Yeah.
Right, sorry, thank you. Good question, Henrietta. I think it's all about skill mix. I think we will always need fabulous nurses in our general practice, and I think if some TNAs can work with them, just as it's great to have GPs, but it's great to have a wider mix of people within a practice. So I don't think this is instead of. I think it's alongside. But what do others think?
I'm happy to share my thoughts, and if there's any other GPs on the call, please jump in. I actually think it may be an opportunity, Henrietta, to do things better, and actually it may be an opportunity to develop the team and actually demonstrate that there really is a really strong career path in general practice. And additionally, it could free up the GPN's time actually to go on for further CPD. One of the biggest reasons that colleagues, GPNs actually can't access development or training programs is they're so precious that they can't be released from practice. Actually, wouldn't it be really great to be in a situation where that was facilitated, actually, because there was a coherent team there? Sam, do you want to come in?
Hi Ali, thanks. Sorry, yeah, just to echo some of the previous comments that have been made, I think it's a fantastic opportunity just to develop our primary care team. The way that I understand how they'd fit in, the dream that I have, is that they'd undertake most of the monitoring of patients. So not the management, that's the easiest way I would describe it. So your chronic disease management will always sit with your highly skilled practice nurses, because they won't be able to make treatment changes per se, but they'll be able to fill that gap. And if you can imagine a future where when September hits and you don't pull and lose all your practice nurses and all your chronic disease appointments to a flu season, that it could be padded out with a wider workforce that was better suited to do that. It just means you'd have more consistent care, and it'd be just sharing that workload out. I think it's an absolutely amazing role that we need to really embrace and bring into general practice.
Thanks, Sam. That's a really passionate statement. Really good to hear. Jill, hello.
Hello. I mean, obviously, I've been a big advocate of the TNA for probably 12, 18 months when Kate and I first started this. But just to sort of give you a bit of reflection in our practice, we've had 2 receptionists join us in the last 12 months whose dream was always to be a nurse, but for variety of reasons, things happened at that crucial moment related to GCSEs and A-levels and things, and didn't quite get the grades. And one of those receptionists now is on the TNA programme due to start at the end of this month, and the other one is due to start the HCA apprenticeship, with the view that both of them will end up on going on the registered degree nurse apprenticeship, and give that career structure that we never had in primary care, so we can grow our own. They are absolutely ecstatic, the 2 of them, as am I. It's taken me 12, 18 months to actually get a TNA in my own practice, but as Sam says, it's about making sure the right person along the journey does the right job. So your HCAs can do your basic asthma checks, you know, the basic things. Your nursing associate can start to build on those skills, and then obviously we can't live without our traditional practice nurses to do that management, but it gives us that opportunity to give that full breadth in primary care, and then your nurses, your traditional practice nurses, can then go on and if they want to do the advanced practitioner or the non-medical prescribing. So you're allowing them to do things that traditionally only happened in secondary care. That's my 2 pennies worth.
I am convinced, Jill, but I did have to ask the question.
Thanks, Henrietta. Amazing questions as always, and I really welcome your questions as always. Any other questions from the floor then? And Leslie, I assume you did your 2-in-1 presentation, your nursing associate presentation and the career structure in one. Is that correct? Or have
no,
you got
but it doesn't matter. It's fine.
Oh,
it's fine.
Gosh. So
because the time's overrun.
Yes, please, over to you then, Leslie.
I'll be very quick. So, and it's just what we've all discussed just then. So it is just the GM nursing pathway really, and it just shows where we're bringing all those things in, that career pathway, the new talent, additional capacity, and embedding new roles. So just our aspirations. If you can move to the next slide, please. So just the nurse pathway there, as we've just talked about, Jill's just mentioned, Sam said, we've all talked about. So from healthcare assistant in a foundation programme, somebody who's very new, that wants to be a HCA, to upskilling them to do some more advanced work in their role, to a senior healthcare support worker with a level 3 apprenticeship, who can move to a trainee nurse associate, with the level 5 foundation degree that we're talking about today, and then onto the nurse associate role with a foundation programme, and onto the registered nurse degree pathway, to a general practice nursing, to the fellowship, the foundation programme, and then onwards to advanced practice. Just a fantastic pathway that, like Jill said, we've never had before in general practice.
You know, I was just about to ask, you know, what are the next steps in the career pathway, but of course you hadn't finished your presentation, so there you go.
Yeah, so they're the next steps, and they're all supported steps as well. So we have things going on for all those different levels to come, and that's fine. I don't think there's anything else in the presentation that we haven't talked about really, and the slides will go out, won't they? Yeah, so it's just about the different offers that we've got there.
So actually the opportunities for a brilliant career in general practice in Greater Manchester for nursing colleagues and nursing teams is bright, vibrant and supported from start to finish. So that's absolutely amazing to hear. Obviously the next bits of your slides are supporting level 2 and level 3 HCA programs. Henrietta.
Apologies, you clicked the wrong button. Sorry.
Oh, okay. Leslie, do you want to finish up or?
I can do. All I can say is that it's a fantastic opportunity, and I think we need to embrace it in general practice and take these roles on. Definitely.
Anything else from the floor then, colleagues?
If no one's got a question, I've got a slight question, because how do you get to be a nurse consultant then, or is that just in secondary care?
Predominantly in secondary care at the minute, isn't it? But
yeah,
I can't see any reason why you couldn't extend what you've set up in place already to have a nurse consultant in primary care. That's one for the future, isn't it?
Certainly. I know Sam's got a hand up, but in my practice, we have a very senior nurse as part of our partner team, and I would actually call them a consultant. So it's you know, it's not a thing, but certainly people can work to that level. Sam?
Yeah, it's the next step up after becoming an advanced practitioner. So it's recognised by I think it's on the HE pathway, but Sonia might be able to correct me there. I'm reaching to the back of my mind when I last saw the multicoloured ladder that ended with level 8 practice, that the nurse consultant is a highly functioning advanced practitioner who's typically you'd expect to be either functioning or working towards your doctorate, so a PhD, who would be taking referrals from a multitude of colleagues, and including doctors, other nurses, HCAs, nurse associates. And if I'm honest, Natasha, we've got them in primary care. They're just not labelled appropriately. We've certainly got the skill. We've got them out there. It's just the terminology for nursing is so ambiguous at times between nurse practitioner, clinical practitioner, advanced nurse, and it all gets a bit blurry and a bit vague. So I think it's some work we need to do around recognising the skill and talent that we've got in our existing really highly functioning workforce. And as we certainly up the ante a bit with our clinical practice, with our nursing colleagues, as we bring in the nursing associate to free up some time with some of the less complex duties, I would see that the role of an advanced practice nurse, as well as more advanced practitioners and nurse consultants, will emerge more prominently.
Yeah. Thanks, Sam.
Well, that's a really great aspiration to end on. Let's bring nurse consultants into general practice and primary care in Greater Manchester. That would be fabulous. And I know we have to work through the different terms and working with regulators. So let's aspire to do that. Any other questions or comments from the floor then, team? No, then I'll round up and say thank you very much to everybody for their contributions. A really great start today. And thanks to Deborah, to Joanne, Sam, Marina and Danielle. Thanks to Leslie for putting it all in context, and thanks for the great discussion, everybody. As always, we are really grateful for your feedback. Please take a couple of minutes to click on the evaluation that's in the chat, and I'll see you all soon. Thank you.
Thanks, everybody. Bye-bye.
Bye.
Thank you. Bye.